Hello everyone and welcome to today's webinar all about add-on treatments and what to ask about them. I'm Emily from Fertility Network UK. Also from Fertility Network today we have Kate Bride and we're joined by Clare Ettinghausen, who is the Director of Strategy and Corporate Affairs at the HFEA. We're also joined by Yakoub, who is the Head of Fertility Services at St Guy's and St Thomas's and member of the HFEA board. This webinar will be recorded and made available on the Fertility Network UK YouTube channel in about a day or two. So if you'd like to refer back to anything, you'll be able to check there, or you can check for a link on our website and our social media as well. So I'll pass over to you, Kate. Thank you.
Thanks so much, Emily, and thanks Claire and Yakoub for joining us this evening. Claire, I wanted to start by asking you a question. We're running this webinar this evening really to tie in with some questions that the HFEA has launched for patients to ask about additional treatments. And I wondered if you could explain why you feel it's important that patients have those questions.
Thanks. I very much welcome the opportunity to be here today. And for everyone listening, the HFEA is the UK's independent regulator of all fertility clinics and embryo research. And we inspect all clinics, NHS and private, across all parts of the United Kingdom. I think that we're in a slightly strange position at the moment with fertility treatment in the UK, in that certainly in England, at least, the vast majority of patients are paying for their own treatment, which is a really unusual position in UK healthcare. We're not used to going into somewhere and paying for treatment and having to make choices that were offered to by medical staff. So we really felt that we wanted to empower patients who often feel, especially on the first cycle of treatment, sometimes overwhelmed by the amount of information and the decisions they're being asked to make. So we work very closely with Fertility Network. We came up with a list of questions that we suggested that patients could ask at their appointments or follow up by email on what are the different types of treatments I'm being offered. If I'm being offered an add-on, why am I being offered it? How is it going to benefit me? Why is it better to spend money on this rather than perhaps put money towards a so-called more routine cycle of fertility treatment? And really empowering patients into questions that they might ask themselves at their consultation. When we work with Fertility Network and patients to get feedback on the draft of questions, the feedback was very positive, that people felt that this would be really useful to be able to have on their phone when they're having a consultation, or to be able to follow up on an email afterwards. So it's questions like, why this add-on? Is it safe for me? Is this going to increase my chances of having a baby? And just giving people the tools to perhaps have those difficult conversations.
Thanks, Claire. I think it's really useful. You can find that on the HFEA website. We have a lot of questions that we've got in already. One for you, Yakoub, here. Someone who said they've had a look at the traffic light system, but they've actually found quite a lot of evidence doing their own research that some of the treatments that are listed as red or amber do actually work, and their clinic recommends them too. And they're asking, how can you be sure that you've taken all the right evidence into consideration when you're giving the advice?
I think that's a very valid question, but it may reassure the person who asks this question that when decisions are made about the strength of evidence and whether it constitutes robust enough evidence to follow, it is made out not just of the committee that the HFA has for advice on what works and what doesn't, but also from experts in assessing evidence, because not every piece or every medical paper has the same strengths. And for the non-trained eye, probably evidence is all the same. But for the trained eye, we'll be looking for something that is robust with as little bias as it is possible. And where you can only have this, if you give you an example of an intervention, the only way of assessing the value of an intervention is if you have 100 couple having this intervention as add-on, the other 100 couple undergoing same treatment but not having this add-on, and they are followed in a very robust way without bias, better if it is blinded. And then at the end of the experiment, it shows that those who had the add-on had substantial increase in their chances of having a baby. This is something then adds value. It's worth investing in, whether this investment is emotional or physical or financial, it is worthwhile. But to say, I have evidence because I use it in my practice and patients get pregnant after taking it, that can go for anything. Patients get pregnant after IVF has failed. Does not mean that IVF has been a waste of time. It means that there is always that possibility, and infertility is most of the time relative, not absolute. And you cannot prove a link. I have the example of the polymint. If a patient had polymint before embryo transfer and she got pregnant, it does not prove that this polymint should be prescribed to every woman who's undergoing IVF treatment. And the same applies with whatever. So putting two and two together and making 49 is hardly an evidence that one should recommend or go by.
Thank you, Yakoub. That's a very clear explanation, and I like your polo mint too. Claire, coming back to you, you suggest in these questions comparing the price of add-ons, but once you've started treatment at a clinic, you're pretty much stuck there really. And if you find out the add-ons there are much more expensive than they are as well, what can people actually do at that point?
Well, I think that there's a few things that patients can do. The first is that all clinics that we regulate, so all fertility clinics in the UK offering fertility treatment, have to abide by the HFEA Code of Practice, which is based on the laws that we're required to implement by the government. And one of the things in the Code of Practice is that every patient has to have an individual costed treatment plan presented to them with full explanations and full costing in advance of treatment. So if someone's given that costed treatment plan and there are things there that they perhaps not sure why it's on there, or perhaps are uncomfortable about being on there, I'd really encourage people to question that before they start any treatment. And that's the point when it is possible to compare prices. I mean, I'm comfortable with the idea of shopping around, because really fertility treatment in the routine sense, as Yakoub has mentioned, really should be the same whether you're in an NHS clinic in Edinburgh or a private clinic in central London. So the idea of shopping around between clinics, I think, is something that we should avoid. However, the reality is that most patients are now paying for treatment, and it has become much more competitive and commercialised with and between clinics. So I'd encourage patients in the same way that they would do when they're purchasing other things in their life to shop around. Most clinics put prices on their websites, and you'd have to do some research to understand what the price list covers. Does it cover all the things that are in your costed treatment plan? Does it cover the drugs, the cost of drugs, which can vary? Does it cover the cost of all the things that are going to be in your treatment? And I know it's uncomfortable to talk about the cost of treatment, but I would encourage you to challenge at a clinic if there are things that you're not comfortable with, and you can do that by email. It doesn't have to be an uncomfortable consultation with a doctor. You can phone up, you could speak to one of the nursing staff, or you could ask for more information by email. So I think that you do, as a patient, have the right to challenge the information you're given, whether it's on cost or other parts of treatment.
Thanks, Claire. That's really good advice about emailing, I think, if you don't feel comfortable about actually confronting someone. Yakoub, we've got another question here about someone who's had IVF for unexplained infertility on the NHS, which didn't work, doesn't really want to change clinics, but says the treatment was very basic and they haven't offered any extra tests or treatment to improve the chances of a second time around. And this person is asking, shouldn't all clinics offer a more tailored treatment if a cycle hasn't worked?
Yeah. I can understand how the public out there will describe a treatment offered in the NHS as basic and super looks. There is only a treatment that consider biology and consider good clinical medicine. Why I say that? Because we require the eggs, we require the sperm, we require the right environment for this to be fertilized and to be developed into embryos, and then good handling of those embryos and choosing the best one to go back, or in some circumstances too. That is the essential. It can hardly be called basic. How you get there, you follow standard protocol that are evidence-based and have been tried and tested. The other misconception that NHS clinic does not tailor the treatment to individual patients there is a lot of tailoring that goes in. I speak from an NHS clinic. If I have a patient now who coming for IVF treatment, who has polycystic ovaries, who has the prospect of producing 25 eggs, I can't treat her in the same way as someone who has limited egg reserve. So isn't that tailoring? Then I go even further. This patient, I'll give her a protocol that involves fulfilling her potential of producing good number of eggs, fertilizing them, using a different trigger, which is a final injection to mature the eggs, that is almost the risk of ovarian hyperstimulation, where the patient can be sick and had to be admitted to hospital, is virtually nil. Freeze all the embryos, weather this storm, and then comes back to have those embryos replaced one at a time. If that is not tailoring, what is? So a lot of that is happening in NHS clinics up and down the country. Just because they don't sell snake oil does not mean that they do not tailor. I personally will never subscribe to giving any treatment that doesn't add value. If it doesn't add value, it does not have to add to the bill. It's nothing to do with being NHS or otherwise. We have the ultimate technology in the NHS, but it is applied when it is required. We have pre-implantation genetic program for couples who have predisposition to passing genetic abnormality to their offspring. We provide 60% of this treatment in the country in the heart of NHS at Guy's Hospital. And so many of our colleagues up and down the country offer similar treatment without necessarily being described as basic or have no way of providing the so-called add-on. Add-on is something that is under investigation, effectively experimental. You cannot be asked to pay for something that's experimental. The only way to test whether it has added value or not is through proper, robust research.
Thank you, Yakoub. That's very clear.
Yeah.
Claire, a question for you, and I'm sorry, we will try to get around to as many questions as we have that you're putting in a questions box, but we had quite a lot sent in already. A question for you, Claire. In your questions, you suggest asking whether anyone employed by the clinic would benefit financially from a treatment. This person said they weren't sure they'd feel comfortable asking that at the clinic, but is there another way of finding that out?
Well, again, unfortunately, there's no simple, easy kind of website where you can find all of that out. Although there are various websites where some doctors declare interest. There's someone, I think, that's called whopaysmydoctor.com. Again, that might be something you might want to email the clinic about. But I think it's about the wider questions about why me particularly specifically is being offered a particular treatment. Will this help me to have a baby or have a successful pregnancy? And again, some add-ons might be offered with the idea that it might be about the pregnancy itself rather than a live birth, which is, I know, a really crude thing to say, but there are some add-ons that if people have had a very long history of miscarriages that might be offered. And lastly, is it an add-on that is going to help me in this cycle of treatment, or am I better saving money towards a further cycle of treatment where you might find out more about my body's response to the treatment and my chances or otherwise of a successful outcome? So I think these are all really difficult questions. And going back to your question, Kate, about is the clinic likely to benefit? I think absolutely those are things that people should feel free to ask. And if it's embarrassing and they want to know the answer, then, you know, I would say do it by email and ask around.
Thank you. Thanks, Claire. A question for you, Yakoub. Someone who said they've looked at the traffic light system, but they actually wanted to have sperm DNA testing, which isn't there. And following on from that, if the male partner did have high DNA sperm fragmentation, would you recommend something like ICSI, IMSI, or surgical sperm retrieval?
I think it is fashionable to do DNA fragmentation, but call me hardliner. I'm not aware of any robust evidence really to suggest that doing DNA fragmentation, A, is detrimental, or having high DNA fragmentation is totally meaning that this person cannot father a child, or in fact, aware of any treatment that conclusively reduce that level. It is linked to a lot of stuff. It's linked to increased risk of miscarriage. You look at the HFEA data with 400,000 pregnancies. We looked at all categories for infertility, including male factor, where you would expect DNA fragmentation to be sky high. There was no difference in the risk of miscarriage in those group of patients against those patients who are having IVF because the tubes are blocked or because they have ovulation issue. So unfortunately, association does not always mean causation, because you can make a case for anything. You can say those who eat ice cream are associated with increased risk of sunburn, and you can make that link. It just so happened that those who ate ice cream at the beach during summer, they might have heat stroke or something like that. It's not caused by ice cream, it's caused by the weather. The same here. Having high DNA fragmentation is part of the process of making sperm. Sometimes it's higher than others, but show me any evidence that treatment of DNA fragmentation works. And the danger is when some people are asked to give up on their ejaculated sperm and have a surgical procedure to use that sperm from the testicle. And that is dangerous. And some invasive and expensive intervention need to be subjected to rigorous and robust research before it's implemented. And I stand corrected. I don't see any professional guideline supporting routine use of DNA fragmentation, whatever and however you hear.
Thank you, Yakoub. Claire, why is it that some clinics include things like embryo glue and time lapse as part of the treatment package if they're still amber on your system?
Well, I think one of the things for me to say on behalf of the HFEA is the traffic light system, by only having 3 colours, is it's crude. It doesn't apply everything under every circumstance, and it was introduced a couple of years ago as an introduction for patients and clinicians to really give an overview of the evidence on whether any of these add-ons would increase the chances of having a baby. So the ones that are amber, it means there is some evidence, but it's not quite yet conclusive. If it was conclusive, it would fall into what we would call routine IVF and should be offered routinely to everyone. So amber means that there's some evidence, but it's not quite there yet. So some clinics might include, for example, time-lapse as part of their routine package, and they would offer that to all patients. Again, if it's privately paid treatment, they might offer it to all patients at a cost, and it would be up for the patient and their doctor to decide whether that would be something that they wanted to pay for, and what's the evidence in their own particular circumstances to pay for this specific add-on. But there are some clinics, I'm not saying it's kind of particularly good or bad thing, who would offer those types of add-ons that we classify as amber to all patients rather than any individual patients. So if you see it on your cost of treatment plan, you shouldn't feel that you've been singled out. It may be that the clinic kind of has this policy of applying to everyone, but it's, again, I think the ball is in your court that to ask the question about why I should pay for it and what benefit is it going to be for me.
Thanks. Yakoub, after 3 failed IVF cycles, is pre-implantation genetic testing on future embryos recommended?
I think it is important to understand exactly what does pre-implantation genetic testing would do. It will not create competent embryos. It will only try to diagnose what is competent from chromosomal point of view and what is not. So if it is applied and it is so happen that all the embryos are abnormal, then it will exclude them and there will be no embryo transfer. That's what it would do. And one could one would accept that an embryo that has no chance of implanting, or if it implanted could lead to a problem, it should not be put back. But sadly, for years, this pre-implantation genetic diagnosis testing has been used in good faith, where it can label embryos are not suitable for transfer, when in fact they are perfectly capable of leading to a healthy live birth. It is being proven time and time again. Now things are moving a little bit, and that knowledge that patient paid for it in money and in embryos lost is filtering through, and the people who believe in pre-implantation genetic testing of embryos are getting now to include all those embryos that previously would have been discarded from the treatment. So it is a moving goalpost all the time, and you cannot also rely on treatment that so far does not have robust evidence to show that compared with using your embryos one at a time or two at a time, if you collectively use all the embryos coming from one cycle, not pre-implantation genetic testing, not any technology will improve on that. It can only undermine it by excluding embryos that are perfectly healthy.
Thank you. Another question for you here, Yakoub. Are there tests to show which is the right day to transfer embryos if you have a longer than usual cycle? And we also had another question about the ERA test, which is obviously kind of related to that.
Yeah, I think longer than usual cycle, it is happen outside IVF. When you are doing IVF, your ovarian function is being put into the mode that is dictated by response to stimulation and the hormonal environment and the milestone events that happen in IVF cycle. So whether the cycle is long or short before IVF is not relevant. But there have been claims that if you do a test, you can pinpoint the right time to put the embryos back. Once again, and I'm sure you will be sick and tired of me repeating this, there has been nothing other than commercially motivated research. And you will not expect the cycle to be the same months on months on months. Otherwise, those who had no luck in one cycle has no chance of ever succeeding. And when we know that patients who fail IVF, they can still go on and have natural conception. If they fail one cycle, they can go on and have a baby with the second cycle, and so on and so forth. So we need to just be a little bit more critical in whatever being put to us. And I always refer to that bit of slogan: whatever you are looking for in Google, you will find it, including finding evidence for things that does not add any, and I don't want to indulge in going through the list of intervention that are claimed to make a difference, when in actual fact, they only make a difference to the bank account of those who sell them.
Thank you, that's very clear. We've got a question here, which I think is for you, Claire, actually. It's kind of comes round to one we had earlier as well. Someone's asking whether there are any treatments, IVF treatments on the NHS they'd have to pay for. And I think that also ties in with an earlier question we had about whether you could have add-ons if you were having NHS treatment. But I'm not, what is the situation with that?
The answer is not an easy one, I'm afraid. It depends where you live, whether it's in Scotland, Wales, Northern Ireland or England. And within England, which CCG is the clinical commissioning group, which is how fertility treatment is funded on the NHS, who is funding your treatment, and whether they will allow you to pay extra for any add-ons that the NHS clinic may provide. But it's not as simple as that, because the days of kind of split, certainly in England, of NHS treatment and private treatment isn't really yet there anymore. So at many NHS clinics, you could have a cycle of treatment if you have it funded by the NHS, and you may go back there as a private patient, a self-funded patient. And many private clinics also have NHS patients coming to them. They have an agreement with the clinical commissioning group that they will take NHS patients. So it's not quite as simple as that. I'd say that unfortunately the answer is it depends which clinic you're at and how your treatment is funded for, which CCG has funded your treatment, whether they would allow you to pay for extra add-ons if you think with your clinician there is something that is worth paying the money for.
Thank you. Yakoub, I think this is probably one for you. Is MAX, magnetic activated cell sorting, available in the UK? Apparently it is in other countries.
I'm not aware that it is available, and I'm not aware also that there has been any study to show that it informed the decision on sperm selection in a way that altered the outcome. But while you are giving me the platform to answer a question, I just picked that one question from Jennifer. We're asking, effectively, she's asking, why am I so vehemently opposed to PGTA? If you work in IVF day in and day out like myself, nothing more frustrating than seeing cycles not working. No matter how many successes you have on the wall around you, because for that one patient, you just don't know what to do to help them. But that does not mean that that desperate situation make us lose sense of proportion. You obviously got me wrong when you said I am promoting putting back aneuploid embryos. If I have this diagnosis reliable, why would I be opposed to it? But I can tell you that it's been estimated that up to 20,000 embryos are wasted to false assignment as aneuploid in the United States every year alone. Is that a treatment that I would like to be part of? I have seen patients who have 6 cycles where they had PGTA, and every cycle they are told there is nothing to go back. All your embryos are abnormal. Surely, based on what we know now, some of these embryos would have been perfectly capable of leading to a baby. If your conscience can accept that, describe me as much as you will, vehemently, or maybe prejudiced or cynical. I am not. I am on the side of the patient just as much as you are.
Thank you, Yakoub. A question here for you, Clare, actually. I feel success rates are often not provided despite asking. Is this something the HFEA can enforce? It's difficult to decide on treatment when there's no real discussion of success rates.
Yes, absolutely, and you know, I can say this sitting here tonight that the clinic absolutely should be talking to you personally about your likely chance of success based on everything they know about your own medical history, your fertility history, your ethnicity, your age, if you have a partner, their health, etc. So your clinic should be providing you with a personalized treatment plan based on your own likely chance of success, which they would use to calculate that. They would use their wider clinic success rates and also the average success rates for people of your age. If you look at the HFEA website, hfea.gov.uk, under the Choose a Fertility Clinic section, you can see the most recent statistics we've published on success rates for every clinic across the UK that we license. And you can search those by age, whether you're using your own eggs or donor sperm. Statistics are often out of date because we wait for clinics to report back to them, and then we wait another year to see about any pregnancy outcomes. So they're not based on 2020 or 2021 data, they're based on 2019 data. And the other thing, if you look on our website, you'll see a lot of information about how to interpret success rates. And really, you know, we're all asking patients to become statistical experts. And you need to look at what is important kind of to you. So it's not only about the success rate, which may not really vary between one clinic and another very much, but which clinic are you comfortable at? Is it convenient to you if you're needing to take time off from work or from other family commitments? Is it convenient for your partner to attend? Do you feel comfortable with what you're being offered? Is the price appropriate for you? And all those other things. So it's not just about these specific success rates, but to go back to the question, yes, the clinic should be providing on their websites the most up-to-date statistics and should be referring to the HFEA website. Please do email us if you find that your clinic is not offering you that information. It is something we pick up on our inspections, and it is something we publish in our compliance reports on clinics about whether they are publishing correct and up-to-date information. So please do let us know if you find that they are not.
Thanks, Clare. We're actually really running out of time, but there are a couple of questions actually, one on immune protocols and one on views on IVIG that I just wanted to put to you quickly before we finish.
Sure. Yeah, I think this is something that will not go away. Some people liken the embryo to a transplanted kidney, for instance, which is not true, because the embryo comes as a package where the system of the body will be receiving it in the way that nature has intended. Otherwise, we wouldn't have 7 billion people on the planet. And just because the IVF, the pregnancy happened to be IVF, is no different from natural conception. The word that scares people to death is the word natural killer cell, because it is understandable that people will feel these are the cells that will kill my embryo, my baby. I can assure you, and you can check, that these cells have never killed anybody. They don't kill embryos. They are part of the package that is involved in establishing implantation or the embryo sticking to the lining of the uterus. And their testing is a mockery, because to test blood for something inside the uterus, the relationship does not exist. To pay money for a test that does not lead to anything and it's only used by a selected group of colleagues, it is not really the way to go. So as I said, natural killer cells, that's just an unfortunate name. And the person who gave them this name is still alive. She's the head of the reproductive immunology department at Cambridge University, none other. So you can see that she, at every meeting, to say she has never regretted anything in her life than giving them this name, because it is not reflective of the truth. Just a little anecdote I give you. When I had once one of my patients, I treated with simple treatment. She had her daughter from the first treatment of intrauterine insemination. Then she came for cycle of insemination, didn't work, moved to IVF for her infertility, so called unexplained, didn't work. Second one didn't work. With the third one, she heard about the immune system and she said, can you give me something to suppress my immune system? I said, I can't test your natural killer cell. You will pay 700 pounds for the test. You might as well pour this money down the drain. Has no value. You will get intravenous immunoglobulin, 1,300 pounds a shot. That is almost irresponsible. I will give you tablets called steroids that cost 5p each. And I just didn't have more stamina to explain to her why this is not necessary, but I knew it won't do her any harm. To cut a long story short, this patient, after 2 weeks, she had a positive pregnancy test. And 3 weeks later, she came for her pregnancy scan. So I was just muttering as I was doing the scan, I can't believe these tablets did anything really. She said, doctor, on that day you gave me the prescription, the pharmacy was so busy, I went home without taking them. Read from this what you will, but there are always putting 2 and 2 together and making whatever number you like. Immune system is immune involvement with implantation, and IVF outcome is a fallacy. Any evidence, show me any scientific or professional body. Does the Royal College of Obstetricians and Gynecologists recommend them? They should know better. Does the British Fertility Society recommend them? They should know better. Does the American Society for Reproductive Medicine recommend them? They don't. What does this tell you? It is hobby horses, and it is good when it is associated with making the bank account healthier. That is all I have to say.
Thank you very much, Yakoub. I think that was very clear what you have to say about that, and I hope people have found it useful this evening. I'm really sorry that we didn't have time to get around to everyone's questions. We will probably, I think, do this another time in the future, because I think it's a really useful way for you to be able to put your questions to experts. But for now, I'm going to hand back over to Emily, and thank you all very much for joining us this evening.
Thank you.
Thanks, Kate, and thank you to Clare and Yakoub as well for joining us this evening and sharing that really valuable advice. And of course, thanks for everyone for watching and joining us this evening. We really appreciate your time and hope you found it helpful. As always, if you need any support, whether that's practical advice or emotional support, our charity is here for you. You can now reach our support line 5 days a week, and we have new support groups starting up all the time, so do keep checking back. On a final note, we'll share the recording of this webinar soon, likely by the end of tomorrow. If not tomorrow, then should be by Thursday at the latest. So you can check our YouTube channel, just type in Fertility Network UK in YouTube and you'll find it. Or you can check the webinar page on our website, or you can check our social media. You can find us on Instagram, Twitter and Facebook. So again, a big thank you to everyone and hope you all have a good evening.
Thank you.
Thank you.